Thank you. Good afternoon, and welcome to today's New York City Council hearing for the Committee on Hospitals and the Committee on Women and Gender Equity. If you would like to testify, you must fill out a speaker card with one of the sergeant at arms in the back of the room. You can submit testimony at testimony@council.nyc.gov
those courses have evolved to also include implicit bias training and debriefing into the course of the simulation framework. An additional way in which we work against bias is that we educate staff on the health and hospitals toxicology testing policy for mothers and babies. Substance use disorder is treated like a medical condition, and it is the goal to get patients to treatment. Written informed consent is required in order to test a pregnant person for substances. And in fact, what we found is that while referrals remain up for referring patients to substances, we do not test.
Okay. Do emergency rooms at health and hospitals locations have a separate section that's dedicated specifically to patients who are pregnant or recently pregnant?
All of our labor and birthing units have something called triage, and those OB triage areas are for pregnant people and assess people for emergency conditions that may come up while pregnant.
And they're in separate sections?
Those are part of the labor and birthing suites. They're generally aligned with those suites.
Got it. Okay. Are there dedicated clinicians in the ER, including nurses, who would address labor and delivery needs? I'm assuming I hope that's a yes.
Yes.
Midwives and doulas continue to face significant barriers to practice. How are you supporting their integration into the maternal health care system?
New York City Health and Hospitals is the largest employers of midwives in New York City. All of our health and hospitals facilities share information regarding midwifery services with patients seeking prenatal care. Across all of our facilities, midwives care for prenatal patients, perform births in the labor and birthing suites, perform postpartum rounds on patients who have delivered, and provide women's health care in our ambulatory care practices. Midwives' scope of practice is typically low-risk patients without complicated prenatal conditions, but in our system, midwives also practice in an integrated way with physicians so they can work with physicians to care for patients who have medical conditions or other complications of pregnancies. I believe you also asked about doulas.
Mm-hmm.
New York City Health and Hospitals does not hire doulas. However, we are the largest referral base to doula services in New York City, mainly through our maternal homes and our social workers. And many of our maternal home team members have taken doula training so that they also, while being as part of the maternal home, they also have doula certification.
Do you know what it would take to have the system hire doulas?
I would have to come back to you. I would have to come back to you with that information.
Okay, I'm really curious about that, and thank you for letting us know. I did not realize that. How many health and hospitals offer birth and labor care?
All 11 maternity hospitals, yes.
Okay. And how many of these hospitals have midwives on staff? Do all 11 have midwives on staff as well?
All 11 do not. 3 of our facilities do not have midwives on staff.
Which ones do not?
I can answer that. Give me one second. Harlem, Lincoln, and Queens.
Okay. And do the midwives work independently or under the supervision of an OBGYN?
Midwives operate independently.
Okay. Do midwives attend low-risk births independently?
I'll say in most cases, yes. I can't attest for what happens on an individual floor of a facility, but in the midwifery scope of practice for health and hospitals, they are given the ability to do so.
Okay. I'm going to go back to the doula question. You said that H&H doesn't hire doulas, but doulas are allowed by state law to be in the delivery room unless there is an emergency.
That
What
is
are the
correct.
policies for determining when the birth is an emergency and a doula should be excluded?
In our system-wide doula policy, the emergency is when a patient is taken for an emergent cesarean birth, and based on it actually is, not just for doulas, but when someone has many emergent, there aren't many emergencies, thankfully, but in the ones that have, I would say, uh, general anesthesia, those generally do not have anyone from the outside in, because the main purpose for having a support person is to really be able to speak to the patient, and normally they are awake during a cesarean birth.
Okay. And are there partnerships? Do you know if there are partnerships that are being built between specific health and hospitals and community midwifery or doula services?
Yes, there are many partnerships. It would depend on the facility in terms of which partnerships they have, but most of our sites do have partnerships with community-based doula services to which they refer patients.
Okay. How does a clinician at Health and Hospitals hospital decide whether to screen a patient for depression, anxiety, intimate partner, domestic violence, or another issue?
All patients are screened for those.
Everyone.
Everyone.
Okay. Are these screenings integrated into a physical checkup or other visit?
I'm not sure I understand the question, but they're in our EMR, and so when a patient presents as part of the intake process,
What I
they're
mean.
asked the screening questions.
Okay, that's what I mean. And how are their mental health? How are they conducted? The screenings. Is it a survey? Is it a piece of? How are the screenings conducted?
They are validated survey tools um, that are either given to the patient to answer themselves in their own language, and or administered, the same tool is administered by either a nurse or PCA.
And how long are the screenings provided? Is there a time period? Every month? Every 2 months?
So the screenings are, the depression screenings probably happen more often, but they definitely happen at the initial prenatal visit. They are repeated again in the inpatient realm or during the birthing process, and then again for the postpartum visit. Those are the minimum amount of screenings. Most patients have more.
Okay. And what resources does Health and Hospital provide when certain issues are present?
So this is where I put in a plug for Woodhull. Woodhull actually has integrated mental health services in our women's health practice. We are the envy of many of our facilities. However, it generally works through referral service. If someone has a positive screen, they may see a social worker, and then we have behavioral health services on site, and we would get the patient to those behavioral health services.
Okay, and congrats. Let's talk a little bit about cesarean deliveries. What, if any, uniform policies does H&H have to help clinicians determine whether to recommend that an emergency C-section be performed on a patient?
So those are based on clinical indications. We follow a standard set by our professional organization, which is the American College of Obstetricians and Gynecologists, as well as other nursing standards such as AWON. A common reason why someone may have an indication for cesarean birth might be a deterioration of the fetal heart rate tracing. Last year, we trained over 90, I would say 8% of our staff in the A1 fetal heart rate training module. And we keep up with those trainings to ensure that certainly patients who need a C-section will get one, and to try to prevent those who don't need one not to get one. other indications might be a severe hemorrhage or something else going on with the mother.
That's actually during labor. What about pre-existing medical conditions?
So
In
clinically, there would probably,
assessments, yeah.
yeah. There aren't many of those, thankfully. I would think if someone had a cardiac issue, we would send them to a specialist to make that assessment. But there are very few, other than the indication of prior cesarean, where we have an informed consent discussion with the patient of whether or not they would like to try for a trial of labor after cesarean. And as long as there are no other contraindications to that, there are some contraindications, but as long as there aren't any, a patient, if they desire, would be allowed to have a trial of labor after cesarean.
Are STIs considered pre-existing medical conditions?
Not necessarily unless someone has an active herpetic lesion, and generally we test for that as per guidance from our professional organization and would offer someone treatment in the last trimester so as to avoid that.
Okay. This interesting. Okay. How does H&H evaluate the rates of cesarean and vaginal births at each facility?
We track our outcomes, and that data is sent to our regional perinatal center, which is Bellevue.
Okay. And how regularly does H&H evaluate that data?
That data is sent monthly to our regional perinatal center.
Who's responsible for reviewing and evaluating the data?
Interestingly enough, the Regional Perinatal Center has a quarterly meeting of the H&H QAPI committee, just like all of the facilities do.
Okay. And in addition to clinical indicators, does H&H review this data by patient, race, ethnicity, age, primary language, insurance type, immigration status, and birthing history?
Through our Office of Population Health, we are starting to get down to that level of data. It right now is not at the point where we're regularly able to pull it up from a dashboard, but in some cases we're able to do that.
Would you say most of these indicators, or one or two, or?
So we have in the most recent years, been entering data for the U.S. News and World Report, and we are able to get down to racial and ethnic data. To my knowledge, we're not at the level of language yet. However, right now, we really have to involve our full data team in order to do that deep dive. We are looking forward to a day when we can pull it up on a dashboard, but we're not there yet.
Any idea when that day will be here?
I will have to get back to you with that.
Okay, fair enough. If disparities are identified in the data, what is the formal process, if any, for investigation, corrective action, and follow-up to ensure improvement?
I'm not aware that we've seen any disparities in the data. I would have to get back to you with that information.
Okay, interesting. Some clinicians may have higher rates of performing cesareans than others because they see patients with higher risk factors, but they may also perform cesareans when it is not medically necessary. How does H&H review clinician records on this issue?
Physicians have something called an ongoing professional peer evaluation, or OPPE, and the department chair reviews this data on, I'm trying to think of I'd have to get back to you with the interval, but it's reviewed by the department chair.
Okay. If a clinician has statistically different rates of cesareans than their colleagues, what is the evaluation process to ensure there is evidence of the need for those procedures?
That would be at the level of the department chair and then the medical director for the facility.
Okay. What methods does H&H use to evaluate differences in cesarean rates across clinicians and facilities? But more broadly, what is the system's process for reviewing outlier patterns and determining whether higher rates reflect clinical need, patient characteristics, or potentially avoidable procedures?
We are using a system called MD Stat, which pulls information from Epic to give provider level information.
And what's the process if there is an internal concern that a clinician performs too many possibly unnecessary cesareans?
Again, that would be at the level of the department chair reviewing the results of the providers in the department. And if there is a concern, it would be taken up to the chief medical officer of the facility.
Okay. If a patient arrives at an H&H location and doesn't have their medical records available on Epic MyChart, what do clinicians do to access medical records for that particular patient?
I have actually seen clinicians do some pretty amazing calisthenics to get patients' records. They will call around, they will ask the patient where they received care. They've even, in cases, made international calls to try to get that data. Very often, patients will have a copy with them, even if it's a paper copy. I've even personally seen like my chart records from other countries. It's kind of
Wow.
interesting. Yeah, patients are pretty good at, pregnant people are good about their records.
Resourceful. Are there any privacy laws that would complicate the process at all?
We would leave it up to the patient to provide that information. And if we're requesting a chart from another facility, there is a process to follow whereby the patient would sign a release of records, and then we could obtain them.
When examining past data on maternal deaths that have occurred at H&H facilities, such as those of Ms. Fields or Ms. Garcia Barrios, what common challenges stand out to you, and what corrective action can you take?
I'm very sorry, Speaker Adams. I'm not able to speak on individual patient outcomes at health and hospitals.
Do you know of any corrective actions that could possibly be taken, just given the knowledge of anybody reading the news or media, not even necessarily investigative? Do you know of any corrective actions that can be taken that could reduce the likelihood of adverse maternal outcomes occurring in the future?
I will just say that in general terms, if there are any adverse events that happen, the hospital and department will go through a very robust root cause analysis of the event in order to see whether or not there were any gaps in care and whether or not there are any opportunities for improvement. From that information, corrective actions will be made, and the corrective actions will be made, in the hospital if that's necessary. If there are any system-wide gaps identified, those would also be spread across the system.
Okay, thank you. I just have one more, just a couple of questions, just turning a different way and speaking about this current administration, and we know that the detrimental impact that this administration is having across the board in a lot of different ways. Following the passage of Public Law 119-2021, also referred to by the president, not by anybody on this panel, I'm sure, as the One Big Beautiful Bill. The New York State hospital system is projected to lose $8 billion. These cuts compound the cuts to Medicaid disproportionate share hospital payments, which also amount to $8 billion. At the Committee on Hospitals executive budget hearing for fiscal year 2026, Dr. Katz suggested that in order to stay afloat, public hospitals in the city would likely trim specialty care options. Could this affect maternal care at H&H hospitals? And how are obstetric units across the hospital system preparing to face possible budget cuts like this?
At New York City Health and Hospitals, we care for patients regardless of their insurance status or ability to pay. Our mission will not change due to these cuts, and we will not back away from serving New York City. We are committed to maintaining stability and safety for our system, patients, and staff. This includes a commitment to maximizing efficiencies within our system while maintaining the high quality of care that our communities deserve. Our system has proven that we can meet challenges head on over and over again. We are confident we will do so again. In coordination with our system leadership, we are working in financial and strategic plans to support our problem solving. As we receive more information about H.R. 1 and other federal actions, we will continue to adapt to best serve our patients and communities safely.
That's a good statement. Just one final question. Just one final question. You did that? Kudos. It's a good statement. I hope the administration is listening. Let's talk. My last question has to do with staffing challenges, which we know is an issue as well. Are there any staffing challenges that maternal care units are facing? And how will these budget cuts affect staffing for maternal care professionals?
At present, we do not have any staffing challenges, and we do not anticipate having any.
Well, that was my last question. That just took away, just kind of deflated my balloon here. Dr. Wilcox, thank you so much for answering my questions. Thank you for being part of this panel today. And once again, thank you for your leadership at Woodhull.
Thank you,
We
Speaker
really, really
Adams.
need you. Thank you for being here. I yield back to the chairs.
Thank you, Madam Speaker. You were going deep, so many questions. I was listening. It's life experience, exposed and to know that how difficult it is, especially when it comes to Black and Brown communities in New York City. Now, is H&H guaranteeing respectful and dignified care in maternal healthcare settings across the city?
We are providing all of our staff with those, back to the front, sorry, thank you. This one? Okay, thank you. So, as I stated a little bit earlier, all of our staff, all of our employees who work in maternal child health must take the courses offered by the Office of Diversity and Inclusion, and these are Introduction to Unconscious Bias and Diversity and Inclusion, a Business Imperative. There are also new modules. There are also additional modules that one can do. And every new employee has to take this because it's in their orientation and our annual in-service. So we must do them annually. I also mentioned our simulation training before, and our implicit bias and equity is embedded to each one of those simulation exercises. Interestingly, when we started the simulation exercises, we were looking for, we use high fidelity mannequins that look like patients in order to try to run the simulations. And we realized that there weren't any that actually looked like our patients. There were no Black birthing mannequins. So we asked the company, and the company actually listened and started creating mannequins for this purpose. So not only do we have Black birthing mannequins, but they started offering different ethnicities in the mannequins so that when you're doing the simulation, you could actually feel like you're actually caring for a real patient.
The reason for that question is just a lot of, I would say, I don't want to say all, but some medical folks, did not cultural competency is a problem for us because they always think that Black people need a different guideline and white people want a different guideline and separated. In the meanwhile, you have to understand it fully. It's not the separation, it's understanding of the person. And many Black women will tell you when they say they're in pain or they have a little difficulty, nobody take them serious. But I don't expect, let's say, H&H to do that. But I just have to ask a question to make sure that we're on the same page. So now I have to acknowledge my colleagues that just joined us, Ina Vernikov. Go on. Does H&H conduct regular cultural humility trainings? I started hearing some to ensure that clinicians are taught how to provide care in a respectful way. If so, how often are this training session required? Are they required of all levels of clinicians, meaning all the way from nurses, residents, attendants, everyone. What is what is taught during these training sessions? Do you believe that they make an impact on a majority of the clinicians, or could the training be reformed to be more impactful?
Thank you, Chairwoman Narcisse. That is a very, thank you. That's, that's a very loaded question. So I'll answer the first question first, which is that all employees must take these courses. It's not certain segments or types of employees. We're all required to take and not just in maternal health, everyone is required to take these courses on an annual basis. There's also a voice system. Voice is an anonymous reporting system, which allows employees on the topic of any harm or potential harm or any adverse event in a facility to report. So everyone is encouraged to report, and the reporting has actually gone up exponentially since the voice system was started. And certainly, if any one of these voice reports involved someone involving bias, then the supervisors would receive that report and would go through the normal processes for dealing with that. There are a variety of virtual workplace inclusion workshops year-round, and these include the following topics: diversity and inclusion in a healthcare setting, interreligious awareness for patient-centered care, having essential conversations, how to be an inclusive colleague, as well as how to be an upstander, which guides participants through proven techniques to actively address and mitigate instances of bias encounters.
Thank you. But do you believe that they make an impact on the majority of the clinician, or could the trainings be reformed to be impactful?
Respectfully, Chairwoman Narcisse, I am not able to comment on the effectiveness of the training.
Fair enough.
Thank you.
Are there ways for patients or colleagues to report concerns about a clinician displaying microaggressive, culturally insensitive, or otherwise disparaging behavior?
There are ways, and I mentioned the voice system, which is an anonymous reporting platform, but also our staff at H&H is not shy, and people would send an email or talk to their supervisor if they encountered any other behavior. But certainly through the voice system, they're able to do so anonymously, and then it would have to go through an investigation.
Could you share with us any of those action been taking place where you have people making report on each other? Like we call it back in the days snitch, but it's not snitch, it's about people's health, people's lives.
We would need to get back to you with that.
All right. What type of policies does H&H enforce that are aimed toward reducing the rate of incidents where patient symptoms or pain are being ignored until their condition escalates to an emergency? How are these policies balanced with the need for the hospitals? For the needs of for hospitals, often with limited staff, to give, because we know you limited in staff, to give attention to all patients who come to the hospital?
I'm not sure I understand that question.
I'll repeat it again.
Okay.
What type of policies does H&H enforce that are aimed toward reducing the rate of incidents where patient symptoms or pain are being ignored until their condition escalates to an emergency? And how are these policies balanced with the need for hospitals, often with limited staff, which you are, to sometimes I said, to give attention to all patients who come to the hospital?
So any adverse outcome can have a root cause analysis, and I'll talk about that process first. So those are probably the worst of the worst, and we don't want cases to end up in a root cause analysis. So there are two other initiatives that I will talk about. One is the early warning system, which is in our EMR, which will alert clinicians, our nurses and providers, about abnormal vital signs, so that they would have to take notice of that. We are actually excited to be implementing a system called Paragen, which is a new fetal heart rate monitoring system, Paragen Vigilance, as well as it automates our early warning system so that it really does give visual cues to our clinical teams when someone may have a deteriorating status. That is not implemented yet. We are starting the implementation and should be finished by the end of this year.
End of this year.
We want to give our entire clinical staff all the tools that they will need to care for patients
Because we
in
know
a
it's
safe
gonna,
manner.
we know it's gonna be very difficult with all the cuts are coming up. And Dr. Wilcox, I appreciate you, but the questions got to be asked because we want to know where we at in terms of our healthcare delivery, especially maternal health being a problem in our city. Um, Language access. State law mandates that H&H develop a language assistance program to ensure meaningful access to the hospital services and reasonable accommodation for all patients who require language assistance. How does H&H interpret meaningful access? And how does it implement the language assistance program? How are you ensuring that all birthing people have meaningful language access?
Language access services are available at all of our facilities 24 hours a day, 7 days a week to any patient who needs it. There are over 300 languages available, and providers, clinicians across the board have access to on-demand phone and video interpretation.
Are there interpreters at language lines specifically trained to provide interpretation services in specific medical fields, such as obstetrics or gynecology?
Yes, they are trained medical translators.
In what cases can a clinician use a family member or or friend for translation purposes? Does H&H advise clinicians to do this or to use language line or comparable service?
Health and Hospitals encourages providers, all clinicians, to use certified translators, which is available through the language lines. We are encouraged not to use family members. However, a patient may refuse the interpretive services and say that they only want to use their family member, in which case we will try to encourage them to use the language line. But if that's what the patient wants, then you know.
You try to accommodate
Yes.
that. One of the things, knowing that I speak about 3 languages or more, I'm trying my fault, is difficult in some culture. When you speak or you on the line, because I have witnessed as being a nurse in the emergency room when things are collapsing around you, right? Patients have difficulty to get on the line to get the communication going smoothly. I don't know from your experience if you had experienced that, but I know that you can tell them one thing and they take it oppositely, total opposite direction with you when they're on the line because they're waiting for gesture. Because a lot of languages, like mine, the one that I speak, they're waiting for the gesture to get it.
Especially in the hospital and in our ambulatory care centers, the video monitors are able to be used and are encouraged so that the patient can actually see the interpreter when they're speaking, and the interpreter can see both the patient and the provider. So It's almost like FaceTime.
Okay. Oh, that is nice. That I rather see that than being on the phone, because I have seen that where people do not get it when you're on the line because they're not hearing you.
Right.
And I'm concerned about the hearing deficit as well while the person is hearing, so they can take it to the next. So last time Dr. Katz was here, I was telling him about my culture, especially the Haitian folks, older one. They like to hear things, they have to see you in front of them. Um, I have my colleagues before she left. She left some questions. Chair Sylvina Brooks Power. I'm going to ask her question before I forget. Could you provide data on which neighborhoods or boroughs of New York City experience the highest rates of maternal mortality and how those trends have shifted over the past 5 years?
We would need to get back to you with that answer.
Okay. Okay. How is the city addressing maternal health challenges through a multi pronged approach that considers environmental, economic, and social determinants of health, in addition to clinical care?
I will say that I serve on a number of committees, as you heard, and so when able, I will take the information that I gleaned from being on those committees and bring it back to health and hospitals. If you'd like a more comprehensive answer, we can get back to you with that answer, but I'll say in general, that's how we function.
In light of the tragic death of Tanisha Evans and Farah Kowe, what immediate steps are being taken to improve follow up care for mothers after childbirth? And how can city agencies ensure that families in high risk communities receive timely support and answers after maternal health complications?
Thank you for asking that question. I believe you're asking about postpartum care.
Mm-hmm.
One second.
Finish this one.
I'm sorry. What page? 9? So we make sure that, I think I have it, hold on a second. We make sure that patients will receive a postpartum visit appointment before they leave the hospital. We give patients the option for either telehealth or in-person postpartum care services. Patients are also able to call our telehealth number if they're having concerns. Prior to being discharged, all patients are given postpartum education. They are it is tailored to the individual patient's needs, so all patients will receive general information about how to care for themselves and what signs and symptoms to look out for in the postpartum period. However, if someone has additional clinical concerns, it will also include that. As I said before, patients who leave the hospital will leave with a postpartum appointment, and many of our sites have implemented televisits, which patients actually prefer because then they don't have to leave with their baby, especially in the wintertime or, if the weather is inclement. So patients have actually shown that they like the telehealth visit follow-up, and our clinicians will conduct, a postpartum visit via that way. If it's necessary for the patient to come in, then we will absolutely also bring them into the practice.
Okay. I think I had some follow up myself that are on that one. As part of your maternal health care model, how many follow up visits do mothers routinely receive after giving birth? And is there flexibility to address that number based on medical or mental health needs?
Absolutely. Um,
Mm.
the postpartum, as you're aware, visit and coverage expansion covers now up to a year postpartum after the birth of the baby.
Mm-hmm.
So, based on clinical needs, patients will be followed up. Someone, for example, who may have hypertension during pregnancy may require more visits than someone who does not have that complication, but we will tailor it to the patient and provide the number of visits that each patient will need.
So, for the standard, no complication, no mental health, how many visits?
Usually it's one postpartum visit within the month postpartum.
Okay. I'd like to know whether electronic health records are fully connected. Um, I know they should be, but I just want to know. Across all H&H hospitals and Gotham clinics, are there still gaps in that system, and what being done to close them?
There are not gaps.
There's
Our
no
Epic
gap.
system is,
So they're all connected.
they're all connected. And if
So
a patient opts, they can even, we can even, if a patient opts in, we can even see records from other places where the patient has gone that are not H&H, only if the patient opts in.
all right. So I know there's different medical record being used, right? So and about the doctor that if they goes to the private doctors, right, and they're in a hospital, you are mostly connected to all physicians now working because do you have to use the same medical record system?
So any patient who comes to us who is not coming from a health and hospitals facility and is coming from a practice that does not use the Epic system, we would not be able to see their records unless they had MyChart, or unless they brought us their records. And many patients do.
Mm-hmm, mm-hmm. Do all H&H hospital and Gotham Health Centers offer the same type of care for pregnant patients? Or are there certain locations that offer more advanced care to pregnant or postpartum patients, particularly if the pregnant patient is experiencing other medical complications?
All of our maternity hospitals offer prenatal and postpartum services as well as intrapartum care. Not all of our ambulatory care sites that are not affiliated with hospitals offer it. However, when a patient calls for an appointment or when they go, and if it's not one that will provide prenatal care, they will be referred to one of our sites that does.
Thank you. When pregnant patients arrive at an H&H location for their regular visit, as they get closer to giving birth, do they consult the same clinicians every time they arrive at the giving H&H facility, or are there no guarantees that a doctor will always be available for a giving patient? Like basically, do you see the same doctors or you see
I
somebody
will
else?
say that most of our sites operate on a group practice model, as do most um, groups, at least in New York and probably around the country. Most obstetrical care has moved to a group practice model where you may not see the same provider over and over again, but they will have access to your records and know your history.
Okay. Thank you. Can a patient request to see the same clinician if they actually repeatedly ask for that? Is that possible?
I believe it's possible. However, I'm not able to attest to that at each site.
Okay. What is the H&H or individual hospital policy for internal reviews after a death occurs? Is it different for maternal death?
All of our adverse events will go through the same process, which is a root cause analysis, which really is a process that is standardized, that digs deep into all of the factors that were involved in evaluating when this event occurred, and any gaps that are identified are analyzed, and if it's facility specific, that will be taken care of at the facility. And if it is something that is a system-wide problem, then that will be at the level of the system, and we will strive to address it there.
Dr. Wilcox,
Yes, ma'am.
I appreciate you all the question. I will be come back and I will pass it to my colleagues, Chair of Women Equity. And I have to say, McIntyre, thank you for being here again. So I'll pass it on to my colleagues, File Lewis.
Thank you, Madam Co-Chair Bruce. Very happy to see you. Thank you for always standing up for Amber and your son and for all those impacted by maternal mortality in New York City. I'm very happy to see you, Dr. Wilcox. I'm going to be super quick. I have like 5 questions. So the first question's around data transparency and accountability. I wanted to know, how frequently does H&H internally review maternal health outcomes disaggregated by race, ethnicity, borough, and hospital site? And how are those findings shared with the public?
As I stated earlier, thank you for that question. Every facility will submit data to our regional perinatal center on a monthly basis. The regional perinatal center compiles it for the New York City Health and Hospitals system. That is shared with our OBGYN Council, which is the council of all of the OBGYN departments across our system, as well as with the Health and Hospitals QAPI, which is the Quality Assurance and PI Committee, on a quarterly basis.
Thank you. And does H&H collaborate with DOH-MH's Maternal Mortality and Morbidity Review Committee to implement specific recommendations at the hospital level? And what accountability structures ensures those recommendations are enacted upon?
Would you please repeat the question?
Sorry. Does H&H collaborate with DOH's MMRC to implement specific recommendations at the hospital level? And what accountability structures ensures that those recommendations are enacted upon?
I am aware that there are certain staff members. I myself was a member of New York City Department of Health's Maternal Mortality Review Committee. I'm no longer on that committee.
Okay.
There are certain other individuals who are, and I'm not aware of the rest of the question. We would have to get back to you with that answer.
Okay. Thank you for that.
You're welcome.
This one is a quick, sorry, let me go to another question. Does H&H evaluate patient satisfaction or trust levels in maternity wards? And if so, how are those evaluations informing improvements in patient care or communications?
There are 2 ways by which that would occur. One is Press Ganey, which is a national system for evaluating patient satisfaction that is not specific to labor and delivery or maternity. Those are on a hospital level. However, those results are shared with the unit level leadership and then shared back to the units and the people who work there. Another system is the New York State Quality, then I'm blanking on the name, but there
So
is
many.
I'm sorry?
There's so many, right? So many different.
I know.
Yeah.
There is a statewide maternity hospital quality initiative that also gives the PREM survey. So it's the patient reporting,
Okay.
survey to patients. And the hospitals receive reports back on the percentage of patients who've answered it. And there are monthly meetings conducted by state DOH and the quality committee to review results and work on methods of improving response rates.
Okay. And I have a quick question on cultural competency. Beyond cultural humility training or within implicit bias training, has H&H implemented or embedded any structural accountability mechanisms, such as patient feedback loops, evaluation metrics or supervisor review processes to monitor how staff apply cultural responsive care in real time?
Other than the patient reporting mechanisms through Press Ganey and the prem surveys that I've just, reported on, I'm not aware of any others.
Okay. This one is about midwives and doulas, and I know you can't answer all of them, but some of
I'll
them.
try.
I'll ask it a different way. Has Health and Hospitals considered the integration or expansion of midwives within hospital-based maternity units since the launch of the New York City Midwifery Initiative? Because you stated earlier that midwives are not, they're independent, but I wanted to know, has Health and Hospitals considered the integration or expansion of the program?
Health and Hospitals has considered expansion of midwifery services, and the leadership of those departments and those hospitals would need to carry that further.
Okay. And which of the programs you mentioned in your testimony earlier ensures continuity of care for low-income birthing people before, during, and after hospital delivery?
I would have to get back to you with the answer for that one.
Okay. Last two questions. What strategies is Health and Hospitals implementing to retain and recruit experienced labor and delivery nurses, midwives, and OBGYNs, especially in high-need hospitals?
Thank you for that question. I would definitely need to get back to you with that response.
Yeah, that would be helpful. And are there mentorship or pipeline programs that specifically recruit residents or medical students from unrepresented backgrounds to specialize in maternal health within H&H hospitals?
We have the Mosaic program, which is not specific to maternal child health, but really seeks to improve the diversity of our workforce and reaches out to historically underrepresented minorities to do rotations in our New York City health and hospitals. And we could probably get you data on that
But
afterwards
so far,
as
the
well.
Mosaic program is like one avenue.
That's the one I'm thinking of now, but we could get you a more comprehensive answer.
Okay, lastly, you were talking about the NYC Baby Boxes program. And I wanted to know who identified the placements of the H&H sites for the NYC Baby Box programs.
That is the loaded question. Thank you. A team between Health and Hospitals and City Hall really worked not only on just the entire project from soup to nuts. And when we were looking at the hospitals that had the largest birthing populations, those are the four where we were able to, I would say, get the biggest bang for our buck. So to offer the baby box to every birthing person,
Right.
and reach about half of our birthing population. Those four hospitals do half of the births in New York City Health and Hospitals.
Thank you for that. I do have one last question. I promise this is the last one. I saw Bruce earlier, and I was like, I have to ask this one. You mentioned earlier, and if you can elaborate on how social workers or care coordinators in every H&H maternity unit help pregnant patients connect to city resources before and after discharge, as well as supporting partners before and after discharge.
So our social workers do that. Also, I was talking about the maternal home, which is in all of our 11 maternity hospitals, and they really aim to really provide wraparound services and screen patients in a standardized way and identify patients who might be at higher risk for undesired pregnancy outcomes, whether it's for needs for social determinants of health, behavioral health, or who have complex clinical needs where they'll need that. So patients are referred to a maternal home team member. They undergo a standardized screening. the maternal home team member will assign a risk tier to the patient that determines the number of times they need to be seen. Sometimes it's, every time they come in, sometimes it's one time. And they really aim to get the patient to the resources that they need. Community-based resources, hospital resources, city resources, you name it. The maternal home is the largest referral base to doula services. They're the largest referral base for other needs that patients may need. And they really aim to be a one-stop shop to help patients in this regard. They're also available in the postpartum period. Certainly if they've met the patient prenatally, that helps. But even if someone didn't see them prenatally and it's determined that they have these needs postpartum, they can see them as well as our in-hospital social workers.
Thank you, doctor. I'm going to hand it back to my co-chair.
Thank you, Chair. What policies does HNH have in place to notify the families and loved ones when a pregnant patient passes away?
Thank you for that question. I will need to come back to you with an answer for that one.
Is there uniform guidance that HNH clinicians provide to new parents about what type of symptoms postpartum patients can expect to experience after giving birth? If so, does such guidance outline specific symptoms that require immediate medical attention? Can a postpartum patient call HNH where they deliver their baby to ask about postpartum symptoms? Do you provide?
They can. All patients receive discharge instructions on what to look out for normal postpartum signs and symptoms of things that may happen, such as preeclampsia. They also tailor the discharge instructions based on whether or not a patient may have additional risk factors. So all patients will receive the general training, and then patients who either anemic or have high blood pressure or diabetes or whatever other clinical condition will receive additional training. Patients may call H&H's telehealth services. They also are given instructions of when they should absolutely call 911 and come in, and or however else to reach the practice.
So now that leaves me with the pre-eclampsia. Do they get sphygmomanometer when they're going home?
Most patients do. We have them available to give to patients.
They get it. They give it to them before they discharge. Okay. How does that was blood pressure?
We try to get it to them in the prenatal period. We try to get it to them in the prenatal period, actually.
Okay, get it.
But yes, if they need it postpartum, we'll get it to them as well.
Okay. How does HNH support a postpartum patient who needs to be evaluated for postpartum symptoms? Do facilities provide lactation pumps and allow children to visit during treatment? So I'm gonna make a joke to my colleagues because she had to run outside to do that. The whole world knows. So that's an open conversation. Because we're not gonna hide anymore to not talking in the back. Because now I love it. Because women now come out in the clinic, they do what they have to do. So we're women.
So all of our sites have facilities, have lactation rooms. All of our sites are baby friendly, which means that they've gone through a national certification for breastfeeding support. Any patient, all patients in New York are covered by Medicaid. They are able to get a pump. They're able to get a lactation pump. If there is difficulty, our maternal home or our social workers will try extra hard to be able to get that for them. We try very hard to enable people to breastfeed.
So now when you said about the insurance Medicaid, I go like, because we're about to lose about 165,000 people. That is a problem for us in New York City. So I'm not going to get to those
So we will have to find another way to get breast pumps to people.
We have to find a way, yes. we are very resourceful folks, and I do trust and believe our medical groups that provide services. We're gonna fight until we die for each other.
Right
So
now, it's
this,
very easy, though. It's literally just signing a script and a patient
Yeah.
can go get one. And they can even have one sent to them.
very difficult. I'm gonna pass it to my colleagues that I just made a joke on. That's your turn.
Thank you, chairs, and thank you, Dr. Wilcox. So I apologize if someone did ask these questions because I was out for a few. So good to see you.
Thank you.
I always love being in the presence of Woodhull folks. Shout out to
Oh.
Miss Grant and Miss Pat who are here. Miss Grant was one of my midwives when I delivered my first baby. So obviously this is something that's very dear to my heart. Dr. Wilcox, I'm going to ask a couple of questions, so if we can keep the answers short. Can you just repeat for me the H&H hospitals where there is a midwifery unit or midwifery personnel? I think you said it was one of the first questions that the speaker asked.
All of them have midwives, midwifery services, except for Harlem, Lincoln, and Queens.
Harlem, Lincoln, and Queens. And Kings County has a midwifery personnel? They do? Okay. I was told otherwise. For Harlem, I know that they had midwives there up until at least May of last year because I was a patient there. So what can you tell us what happened there or what has happened there?
I'm not able to comment on that.
You're not able to comment on that. Okay. Is there a pathway for reinstating a midwifery unit at Harlem?
We would have to get back to you with the answer on that one.
Okay. And then of the other two facilities, is there a pathway for midwifery personnel or units at those two hospitals as well?
I know there's a desire to implement a new service. A new service does take
They
some
did not have
planning.
midwifery before those two, the remaining two? Queens and I'm sorry, I forgot the other one.
Lincoln.
And Lincoln, they did not have no, okay, so sorry. So
They
you were
would be
saying,
starting de novo. So in order to start a new service, it requires a business plan, and they would have to, probably hire a director, and then
okay.
start hiring, and then you know what I'm saying. Like it's
Sure.
a process. So
And but is it a process that is supported by H&H in some
Could be
capacity,
supported.
or it's the individual hospital that essentially has to?
the hospital would have to initiate it. It would be supported.
Okay. Okay. Now, just jumping on some questions about data. I don't know if you have it. Can you share just kind of general rates of C-sections performed at H&H hospitals that have midwives versus those that do not?
I'm not able to give you specific data on that. I can tell you that the overall C-section rate for health and hospitals is lower than the New York State average.
But and that rate that you're referring to, this is from data from what year?
(2024).
2024. So you can't share the rate, but you can tell me it's less than the rest of New York City?
I can share the rate. Please give me 1 second. 32%.
32% as of 2024.
Yeah.
Okay.
Thank you.
That's the H&H rate. And then the citywide rate?
Page is that 9? Okay, sorry about that. I just need to get to the right page.
That's all right.
C-section deliveries for the health and hospital system was 32%, which is on par with the national level. The C-section rate for New York State is 33.9%.
Okay. And do you know, and you can get back to me, I apologize, have these rates increased or decreased since the pandemic, or increased or decreased since the citywide doula initiative?
I would need to get back to you with that.
Okay. Specifically, I'm interested in the impact of the citywide doula initiative. If you can share, the program started in 2022, 2023. So if there's any
I'm
comparative
aware
data.
of an article that we could send you that showed that initiative did not have any effect on C-section rates. That was
It did
put
not.
out, but it did not. From that article, which we can share with you, I'm not sure of any updated information.
Okay. And then I know I have 30 seconds, but can you share if midwives specifically, if there's a process for them to report concerns about staff in their interpersonal relationships or instances with patients?
All employees, and that is all employees in New York City Health and Hospitals, are able to anonymously report any interaction that they feel is adverse or not correct through the anonymous voice reporting system. It is actually
I have one more
can
minute?
go through on a
Thank you.
unit level, and there's a way that it tracks to the correct supervisor, but it is anonymous and it will be investigated. So and reports through that system have been encouraged, and there is a lot of reporting through that system, and it's handled, I think, through our risk management and quality management
Okay,
departments.
and that system, and the chair's going to give me a few more seconds, so thank you. That process is the same process for a staff member reporting treatment of a patient or treatment towards themselves of
It
a
is, but
superior.
it's tracked differently. Like it's actually a very smart system. So depending on whether it's like a patient occurrence or a staff occurrence or even like a environmental issue, it will track it to the correct place to be addressed.
What is the I guess what is the accountability piece? What is that timeline? I'm curious. I know that I think the speaker had asked before. I don't know if you were able to respond, but here at the council, if there's a complaint lodged about whoever, it is very quickly investigated. There's some portion of it that there's a transparency piece to it. I'm just curious, what can you share about what that process is like?
So
what's the accountability piece?
As a manager, which I am, I get reports from Voice all the time. I get it on a daily basis if one is lodged. If it's something that would involve HR, I imagine that would have to go through an HR process, which I'm not privy to, and we could probably.
And is there always a response, even if the response is we're investigating it? Is there always a response to each of those anonymous complaints that are reported?
That's a good question. I know it goes to the managers. I guess the manager would then have to follow up with. It's anonymous, right? And so if the report mentions names, I imagine that then the manager would have to then go through a somewhat of an HR process and investigate that. If it did not involve a patient, if it involves a patient, the medical record number is there, and then we can look and see who was attending to the patient, and the
But if
manager would
if
investigate
it was
what's
lodged
going
from
on.
a staff member, you're not sure if there is a response,
We
a
can
recognition,
find out
a
and
receipt.
get back to you. I'm not sure of
Okay,
the ones that don't. I'm mostly clinical, so the
You got it.
clinical ones definitely come to me. I'm not aware of
okay.
the ones that are
All right,
not.
thank you. I have more questions, Bob. So sorry. Look at that. I know, my home mom. What trainings are? I know that I think you had mentioned this while I was out. I was streaming it. My apologies. I guess what are the specific steps that you all take for ensuring just a positive work culture for the staff? I mean, I've been a patient at Woodhall, and I have just gold stars reviews from my experience, and of course I want that to be the experience for every person and every family. I know that some things have changed at this specific facility. The reason I raise Harlem is again because I was a patient there also, and again I want that that experience to be the standard for everybody. So what can you share? And I know that you're specific to one facility, but what can you share about what do you all do for work culture, specifically integrating? Because I think it's tough, and I know it's tough, integrating this the midwifery practice in these units. I think Woodhall is a specific example of when it works super well. And in my experience working with midwives, throughout the city, sometimes that is not, or oftentimes, almost no times is that the experience of midwives and across the other H&H hospitals. So what can you share? What specific examples can you share of what actions or steps are taken to replicate that, to ensure this like positive work culture, to just ensure that there is positive work experience and integration, so that the patient, ultimately that pregnant person, is benefiting from this like comprehensive care?
Thank you for asking that question. I hear a lot of different questions in your question. I will say that as a system, we recently launched an eye care initiative, both a pledge and also a training. And the eye care initiative is really centered not just on maternal child units or labor and birthing units. It's really hospital wide to instill empathy and caring in all who work at New York City Health and Hospitals. ICARE stands for integrity, compassion, accountability, respect, and excellence. And every employee is expected to go through this training and also sign a pledge that we will identify the ICARE values.
And this is a new initiative, you said?
It's fairly new.
Okay. And it's been implemented in every H&H?
Yes.
Okay. And how often do they have to do this?
So annually. Thank you.
Okay. Okay. I'll pass it back to the chairs. Thank you so much. Thank you,
Thank
Chair.
you.
Now we're gonna go a little bit again on mental health. If a pregnant patient present with existing mental health challenges before or during their pregnancy, what step do clinicians take to provide additional supports to the patient during the course of their pregnancy and postpartum periods? Um, do you have suggestions for other methods to improve the delivery of mental health care services to such patients? You know, the second part is yours.
Thank you for
Directly.
asking that. I know, you see me nodding. So, uh, patients with pre-existing mental health services hopefully are receiving care. As a clinician, we would ensure that they are receiving that care, whether it's inside our health and hospitals walls or externally, and that they're still following up with their care provider. What we have found to work well and what we would like to, thank you. Through our maternal home, which you've heard me talk about several times today, we have made over 1,300 referrals to behavioral health services. So if patients do not have a regular behavioral health provider, that they can get the care that they need. What we have found works really well, and we would love to in the future replicate around, is to actually have behavioral health services embedded in women's health. That's not always possible, whether it's due to physical constraints or other workforce-related constraints. But ideally, we found that that's a model that works really well. However, ensuring that patients are following up with their behavioral health provider while also receiving their prenatal care is a model that we follow.
Have you find it difficult for patients going through pregnancy and seeing their mental health providers? Like
I think it
behavioral health,
depends
that we
on
call
what the clinical scenario is. If it's something like depression, that's a little bit different than someone who's bipolar or schizophrenic or some of the other mental health conditions that we see.
Okay. Many medications used to treat mental health conditions are not evaluated for side effect during pregnancy, leaving some clinicians unwilling to prescribe medication or deferring to another clinician, which effectively delays treatment to the patients. What training or support does H&H provide to clinicians to be educated and confident in treating pregnant patients? What policies does H&H have to ensure pregnant patients receive necessary medication? And I don't want to make a joke. You know, recently there was something, aceta, whatever. Let's go on. I just have to say it.
Yeah, I'm not sure that there's hospital-specific training. Definitely, my professional organization, which is ACOG, certainly supports uh, mental health treatment during pregnancy and certainly not stopping it. I think we can all acknowledge that there are silos in medical care, and not all disciplines are aware of medication use in pregnancy. Certainly, if we look in the micromedics or other pregnancy lactation, there's a pregnancy lactation encyclopedia. It's fairly accessible online, and most medications do receive a pregnancy rating about whether or not it can be taken during pregnancy. Generally, medications that are A, B, or C can be taken safely during pregnancy. Certainly, D or below would not be recommended. And it certainly involves a conversation with the patient, obviously. And so I'm not aware of any specific training other than what we would receive during our medical training in terms of how to access that information. But certainly we can get guidance through our professional organizations.
Um, what my the approach that I use is just like if a patient have to deal with the GI problem, acid thing, so I will get the GI input before even the doctor prescribe it. I will check for it. So I don't know if we still do that. And if it's something with a heart, then you check with the cardiologist and combine it together.
Right. So what you're suggesting is that our behavioral health colleagues contact us and consult us, right, if a patient is pregnant.
Make sure.
And they do.
All right. Pregnant patients who struggle with substance use may be afraid to tell their clinicians. What policy does H&H have to offer to support patients to disclose important information without fear of immediate intervention by the Administration of Child Services?
So we screen patients for substance use disorders, and by screening, I mean we offer a standardized questionnaire to ask about substance use. It is a standardized questionnaire that is validated. It's a validated tool, and if a patient reveals that they have a substance use disorder, we will direct them to care, medical care.
And about the concern for Administration of Child Services.
So we've
How we
really
address that.
steered away, and we have policies for both maternal testing and newborn testing that will not allow us to order testing on a patient without specific informed consent, and that informed consent would include a discussion about potential involvement of Child Protective Services. So we really try to steer away from testing and just offer a consultation to a patient and referral to substance use services so that they can get the treatment that they need.
Okay, thank you. New York State law, the Maternity Information Act, requires every hospital and birth center to distribute to all prospective maternity patients at the time of pre-admission and to members of the general public upon request a statistical profile of that hospital's birth-related practices. Do H&H hospitals comply with this law? If no, why not?
Page 4, thank you. It's page. Here, this one. H&H provides a data profile of birth practices at the facility level.
You comply. Okay. Now, it's been a little long process. My colleague, do you have any more questions? No? Dr.
Oh, I'm so
Wilcox?
sorry. Do I have any questions?
No, no, no.
Oh.
Actually, I was asking her if she has any question. You have any question? You're done. So I want to say thank you so much for your time, Dr. Wilcox. You're a good friend, and I thank you for coming. And you're not in the principal's office.
Thank you, Chairwoman Narcisse. Thank you,
Thank you.
Chairwoman Luis.
Appreciate
Thank
you.
you all. Very
Hope to
much
see you soon
appreciate
in
it.
the next conference.
Thank you.
All right. Bye. Thank you. Okay. I now open the floor to public testimony. Before we begin, I remind members of the public that this is a formal government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Further, members of the public may not present audio or video recording as testimony, but may submit transcripts to such recording to the Sergeant at Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant at Arms and wait for your name to be called. Once you have been recognized, you will have 2 minutes to speak on today's hearing oversight topics on improving maternal health in New York City. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant at Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. When you hear your name, please come up to the witness panel for the first panel. The first panel is Patricia Luffman, Bruce McIntyre. Thank you. You may begin.
Before I begin, I would respectfully request that I be allowed to exceed my time limit. I know that you had a lot of questions to ask of the previous individual. With your permission.
Can I say no to someone that invested so much time in this process? So I will allow you to finish your statement.
Thank you.
you.
Greeting Chairpersons Narcisse and Luis, Council Members Gutierrez, Bernikoff, and I think that's it. My name is Patricia Loffman. I'm a certified nurse midwife, the former director of midwifery service at Harlem Hospital in New York City, a founding member of the New York City Maternal Mortality Review Committee in 2018, and a member of the newly created New York City Council Maternal Health Steering Committee. Of note, I share with you I have missed only 2 New York City Maternal Mortality Review Committee meetings in 7 years. Consequently, I have extensive experience with the issue on which I testify today. I speak in support of Resolution 1082-2025, introduced by Deputy Speaker Ayala, resolution calling on the New York City State Department of Health to confidentially share data regarding adverse maternal health events from the New York Patient Occurrence Reporting and Tracking System with the New York City Maternal Mortality Review Committee. Every year in New York City, between 50 and 60 women and birthing people die from a pregnancy-associated death. Black, non-Hispanic women are about 5 times more likely to experience a pregnancy-associated death than white women. As many of you know, the New York City Department of Health and Mental Hygiene first convened the Maternal Mortality Review Committee in January 2018 and was then signed into local and state legislation through the New York City Council and New York State legislation. The New York City Department of Health and Mental Hygiene provides operational support to the committee, conducts data analysis, and produces collaborative reports with the New York City Maternal Mortality Review Committee. The New York City Maternal Mortality Review Committee is independent, diverse, multidisciplinary team, including 40 specialists with expertise in midwifery, family medicine, nursing, psychology and psychiatry, anesthesiology, maternal fetal medicine, obstetrics and gynecology, doula services, patient advocacy, social work, health systems, addiction treatment, and violence prevention. In total, 70% of members self identify as Black or Hispanic women, the two groups most affected by these deaths, and 65% of members identify as clinical and 35% identify as non clinical. We meet monthly to review each maternal death in New York City to understand the contributing factors leading to the death as well as opportunities for prevention. Since 2018, the New York City Maternal Mortality Review Committee has reviewed almost 400 deaths. We actually have reviewed 391. According to the New York City and New York State legislation, two MMRCs were established. The New York City MMRC reviews deaths that occur in New York City. The New York City MMRC then shares data with the New York State MMRC. According to the New York State legislation, the New York State MMRC should provide information and assistance to the New York City MMRC for the performance of its functions. And the New York City MMRC may request and shall receive upon request from any department, division, board, bureau, commission, local health departments, or any other agency of the state or political subdivision thereof of any public authority, as well as hospitals established pursuant to Article 28 of this chapter, birthing facilities, medical examiners, coroners and coroner physicians, and any other facility providing services associated with maternal mortality. Such information including, but not limited to, death records, medical records, autopsy reports, toxicology reports, hospital discharge records, birth records, and any other information that will help the department under this section to properly carry out its functions, powers, and duties. Since 2018, the New York City MMRC has requested access from the New York State MMRC and other New York State DOH representatives to a critical data source, the New York Patient Occurrence Reporting and Tracking System, NIPORTS. NIPORTS is a statewide mandatory reporting system that collects information from hospitals and diagnostic and treatment centers about adverse events, including data on maternal deaths and serious injuries. NIPORTS requires hospitals to report adverse events that were not the result of the natural course of an illness and caused by an undesirable development in a patient's condition. Reporting must be done within 24 hours or one business day of becoming aware of the event and must include the date, nature, classification, and location of the event, as well as affected patients' medical record numbers. Severe incidents such as wrong side, wrong patient, wrong procedure surgery, unexpected deaths, and certain equipment malfunctions have specific, stricter requirements, including an in-depth root cause analysis and corrective action plan, according to a New York State Department of Health document. An expert New York State Department of Health committee assembles to conduct the root cause analysis and develop an action plan for the hospital or facility in response to a severe incident or unexpected death, including maternal death. For example, NIPORTS codes 911 and 912 are specific categories for reporting wrong site, wrong patient, and wrong procedure medical events within New York's mandatory healthcare reporting system. These codes are used by NIPORTS to log errors that occur in hospitals and other treatment centers. These are then grouped into categories of root causes, such as the level of clinician providing care. Was this an intern? The patient to staff ratio. Was there adequate staffing? The time of day or night? Communication failures? Non-compliance with existing procedures? Inadequate orientation or training? Some of the categories might overlap within cases. We noted that most Code 911 and Code 912 events had at least 3 root causes, suggesting a specific and direct causal relationship as well as multiple contributing factors such as environmental conditions, increasing the chance of an adverse event. Complex cases had as many as 10 root causes. In sum, this data source is critical to the New York City MMRC understanding of what occurred in the hospital and what was recommended as a corrective course of action after a maternal death occurred. The New York State MMRC already has access to this data and has presented it in past public forums. The New York City MMRC also requires access to this data. Access to NIPORT's data would support the New York City MMRC's full understanding of hospital deaths and provide critical information on issues that may have affected the decedent's course of care that are not routinely documented in the medical records, again, such as staffing. I am requesting on behalf of the New York City MMRC that the City Council assists us in gaining access to this crucial data source to enable us to fully understand and make determinations and recommendations for the maternal deaths to enable us to give full justice and honor to the women and birthing people who have died and their families and communities who have lost a loved one. And we just listed all of the different causes that would be included under NIPORTS. Any questions?
Well, I can say thank you. This is very detailing for me, and I was listening every step of the way. So, how long you been doing this work?
43 years.
43 years. And you have seen it all.
I've seen it all.
So, what, beside that, the access that you need, what else you think that we can do as a community under the climate that we are right now, about to lose so much, and the cuts is ridiculous?
You know, I've always said I worked at Harlem Hospital, and we took care of the first women who suffered with HIV/AIDS. And in 1984, we didn't have a lot of money in Harlem Hospital, but we had really good outcomes. So often it is not money. Money is important, but it's not always money. We had a culture at Harlem Hospital that promoted excellence. We had a midwifery service that was well integrated into the department. What generally happens throughout the Health and Hospital Corporation midwifery services, it really depends on the culture that is established at the leadership level. And so not all midwifery services practice the same. Not all midwifery services, the midwives in the services are enabled to practice to the full extent of their education, of their training. They're not always supported. So I think in terms of what we are going to experience now, it's going to challenge us as to how solid can we be as clinicians, as colleagues, and as departments.
Thank you. Any questions from my colleagues?
Thank you, Chair. And thank you so much, Mother Pat, for all of the 43 years, the volunteer service, and this really, really thoughtful testimony, really detailing the amount of work that goes into this review committee and the goals, what the end goal is, what the product is supposed to be. I was not aware that you all even meet monthly since 2018, and I think that is incredible.
We meet monthly, and we review approximately 5 to 6 cases every month. And I can share with you that it is taxing on everyone. I'll give you an example. One case that we reviewed was a woman who was experiencing mental health illness. And she was on a subway platform. And as the train came in, she locked eyes with the motorman, the conductor of the train. and she mouthed to him, "I'm sorry," as she jumped onto the train tracks. And so when we talk about the availability of mental health care, one of the recurring themes that we see in the cases that we review is number one, the fact that most of these women experience mental health illness very, very early in their lives. It did not begin when they became pregnant. It began long before pregnancy, and then they became pregnancy. And then what? We do not have sufficient mental health services, either psychiatrists, mental health nurse practitioners who have prescriptive privileges, who can prescribe medication, because often these women are in crisis, need to be stabilized before you can even begin to treat.
Can I thank you so much again, and thank you for volunteering your time and being so detailed in your testimony. My one question is, I know your ask is for the council's assistance to help you gain access to this data. Can you share what has the response been in the past? Like, what is the reasoning that it's not already shared with the review committee? What is the challenge?
We do not have an answer to that. We have requested, it just has not been provided.
And this is from the state.
Yes.
Okay. Okay. Thank you. Thank you, Chairs.
We hear you, and we're gonna find out. I know she's gonna determine. That's crazy because you need it. Yeah, yeah, that's the word. Unacceptable because you need the data for a good purpose. So it's not something you want to do just to do. It's to save lives. Okay. Anything? That's it. All right. Thank you. So now we're gonna hear from Mass. Hmm? Yeah, yeah. He's gonna testify. Yes, Mr. McIntyre.
Hello, peace to the city council members. It's good to see you all. Peace and love. So I just wanted to share a testimony amongst when it comes to patients and mental health as well. So when it came to me in my situation with my partner who passed back in 2020 of April, Amber Rose Isaac, who was grossly neglected by the hospitals. She was grossly neglected by two hospitals under the same branch, by Montefiore Moses and under Montefiore Einstein, where she received the same treatment at both facilities, which was truly gross neglect. And after her passing, there weren't any services that were made available to me. In her passing, there were more services that were made available to her mother, the grandmother, than there was for me as a father. And while seeking help, the hospital was trying to offer me therapy, but without even being properly evaluated by the therapist, she was so quick to try to throw drugs at me like Xanax and other stronger antidepressants, which is a vicious cycle that we have seen throughout time within the Black and Brown communities, especially the underserved communities. And back in those times, I was thinking to myself, how am I supposed to take care of my newborn child who just lost his mother if I'm doped up on drugs and I'm left incompetent to take care of my child, and then it becomes a whole other issue with my child being taken away from the state. And families experience that, unfortunately. So I was wondering what the city in New York State is going to do with situations like those when it comes to fathers who suffer from maternal mortality or morbidity. What services are going to be made available to parents like them which present in a more holistic approach. It was the midwives and the doulas who actually offered me grief counseling without taking a cent out of my pocket, because they truly cared. And instead of the system that was working against me, it was the midwives and it was the doulas who were presenting services to me to assure that I was able to take care of myself and sustain myself as well as my child. They introduced me to lactation consultants. After my partner passed, who held a strict vegan diet, I wanted to make sure and assure that my son was receiving the same nutrients and vitamins that he was receiving from his mother, which the doulas, which the lactation consultants partnered me with other donors who matched the same diet that my partner was receiving, and I was able to get free breast milk for almost 2 years. So I was wondering, what the hospitals are doing to implement services like that, and also how the hospitals are preparing birthing partners for a maternal loss. Of course, with my situation, we weren't made aware of what was going on with Amber. We weren't told that she had HELP syndrome until the day that she passed away, which should never happen. And we weren't told what she had until the day that she passed away. And instead of, and the hospital allowed me to be in the hospital with my partner because they knew I was the father. So after her passing, they told me that due to her passing, she was no longer alive to attest that I was the father, which made me go through this extensive program, a process just to be able to gain the own rights to my son. And it took almost 2 years for me to gain the rights to my son. And it took me almost 4 years to receive the birth certificate with my name on it. And you have to get all of that process before you can open a legal case against the hospitals. So I was wondering how the hospitals are preparing people for situations like that to make that a smoother process for parents like mine. Because due to not having those available to me, my son wasn't able to receive child tax care credits. I wasn't able to receive, at the time, stimulus checks for my child as well. And I was forced to struggle because of how the system viewed me as a black father. And, and instead of making that process a lot easier for me, which should have been done, I was forced to take a very hard route with the force and pressure of the hospitals working against me. Even to this day, they're still refusing accountability for the loss of my partner. So I was wondering, what the hospitals are doing to present truth and reconciliation, and how that's being implemented in the hospitals. Amber's head surgeon that was grossly neglecting her, he was the one that performed the autopsy on Amber, which is a huge red flag. And the medical examiner never stamped off on the autopsy report as well. I was told by the funeral director to reach out to the police, file a report, which I tried to do, but they told me it was malpractice, which means it was being guarded by malpractice insurance, and that it was a malpractice case, so I couldn't file a report with the police. So there's a bunch of red flags that were going on in my situation that made me suffer. And I suffered a great immense of emotional loss, which the city has not recognized because we don't have systems, we don't have policy in place such as the Grieving Families Act, that would allow truth and reconciliation and also accountability against the hospitals. My partner was supposed to graduate with her master's degree. She wanted to open up her own school, which she was cut short. She passed away the month after she was supposed to, or the month before she was supposed to graduate. But the city only recognizes her from the last job that she worked, and they do not recognize the potential earnings that she was also going to gain, which also, put a huge strain on myself and my family. So I believe that with the support of the council in passing and helping with the Grieving Families Act and supporting the Grieving Families Act, we can create a safety net for families like mine so they don't have to suffer.
I have to say by saying my apologies for all the struggle you have to go through.
Thank you.
And yes, there's a culture where male was not most of the time not part of the conversation, but there's a lot of legal things that we talk about which I will not answer because I'm not a lawyer. I'm a nurse. I don't have that background for me to actually talk about those legal aspect of it. But as far as the policies that we can put in place, that we will work with you. We'll try to do our very best because I appreciate your advocacy because what you're doing actually prevent a next person from getting. You take your pen and you put it into advocacy, which is
Exactly.
that's why I love New Yorkers because when
Exactly.
things happen, we don't just sit on it. We try to do our very best to prevent from somebody else from learning the hard way, just like we had to learn. Like my grandmother said, if you got hit or or your foot got caught into a pothole, why would you let somebody else go into the same pothole and hurt themselves if you
Exactly.
care? So you showing that you care. So I thank you, and Dr. Wilcox, Wilcox still sitting here listening to you. So I'm sure we'll be in a collaboration to do our very best. And since you're talking about a single dad, it's not that easy. A single mom is not easy. So a single dad, I know, is very difficult, quite difficult.
Definitely.
So my apology, and then we'll do our very best to, put something in place.
Thank you.
Thank you, co-chair. Just to echo some of what she shared, Bruce, you never said any of this. Every time I saw you, you never shared this.
I know.
So there's a lot of legal aspects to this, and I would love to talk to you after the hearing to see what resources we could provide to you. Besides the bill, which we will fight and advocate for, it sounds like you need some additional restitution in regards to what happened to you over time. And I'm very sorry that you went through all of those obstacles while going through everything that you was going through. So I would love to talk to you after this to see what additional resources and support we could provide to you.
Of course. Thank you. Thank you.
Like we said, we can see you, we hear you, and thank you for sharing. And my colleagues, Jennifer, anything? No. Thank you. Okay.
Of course. Thank you.
Thank you. The next panel is Lacey Tauber, Judith Kutchin, Elizabeth Grillier.
Hi, everyone.
May begin. Thank you.
Thanks. It's really hard to follow that, so I just wanted to say thank you to the two previous speakers for their advocacy. And I also want to thank you all for holding this hearing today and calling attention to this issue. I don't think it's a coincidence that we've got 3 female council members from Brooklyn at the dais right now, especially because 4 out of the 5 community districts with the highest rates of pregnancy-associated death are in Brooklyn. And that is why the borough president, who I'm here to represent today, has made this such a high priority for his work. And great. And, we want to thank the speaker for really always being a leader on this. Our own maternal health task force, which, as Dr. Wilcox mentioned, she's a part of, as well as some other folks in this room. And also Tamisha, who's our maternal health policy analyst, who's here. So I'm going to summarize our testimony for time. And I don't think I can add anything about how critical the NIPORTS data is. So just wanted to say, it's smart for the council to put forward these resolutions, calling for this data to be audited and readily available. And ultimately, the purpose of collecting this data is to inform choices about funding and programming that aim to improve outcomes. We already know that the majority of pregnancy-associated deaths are preventable. And the borough president really hopes to continue to partner with the council on a number of solutions, including investing in public hospitals, including investment in fair wages and adequate staffing so people don't feel they need to leave the borough for access to quality care. Investing in midwifery care. Maternity care provided by midwives has been associated with improved birth outcomes, fewer C-sections, lower preterm birth rates, lower episiotomy rates, higher breastfeeding rates. However, Woodhull is the only Brooklyn public hospital, as you heard, that has really centered midwives in obstetric care. And the last one is expanding the perinatal mental health workforce. Just quickly, this year, the BP Reynosa was proud to announce a partnership with Brooklyn College to design and implement an advanced certificate in perinatal mental health, and just wants to keep working with the council on this and other initiatives. Thank you so much.
Hello, everyone. My name is Dr. Judith Kutchin. I am the first vice president of the New York State Nurses Association. I have worked at Woodhull Hospital for over 34 years, where we provide high-quality healthcare coverage for all New Yorkers with regard to their background and legal status or their ability to pay. As the frontline healthcare workers, we strongly support immediate action to address racial and economic inequities to care. We are especially outraged by the persistence of unacceptably high maternal mortality and morbidity rates for poorer mothers and for women of color. We all know the statistics about maternal health in New York across the U.S. so I don't need to go into detail. But we think it's unacceptable that the U.S. maternal mortality rate is more than 3 times that of similar developed countries. And while New York State has made some progress, total rates of maternal mortality and morbidity remains high. In addition, it is alarming that in New York, the mortality rate for Black mothers is 5 times higher than that for white mothers. The State Department of Health admits that higher rates of harm suffered by Black mothers show longstanding health disparities resulting from inequitable care and systematic racism. The DOH also recognizes that racial disparities in access and quality of care are a public health emergency. As nurses, we know that maternal deaths and harms are almost entirely preventable with proper staffing, culturally sensitive care, training, and funding. If we are going to fix this crisis, we need to have the information and data. We need to assess the scope of the problem and factors that cause it. That means that the State Department of Health must share its data with the New York City Health Department and the City Maternal Mortality and Morbidity Review Committee. The state must also make sure that the data we are getting is accurate, timely, detailed enough for us to begin to get this crisis under control. For these reasons, we urge the City Council to pass resolutions 1082, 1085, 1086, and 1087. Thank you for holding this hearing to address this and giving me the time to speak. Thank you.
Thank you. Next.
Good afternoon, chairs and members of the committees on hospitals and women and gender equity. My name is E.B. Grelier, and I'm the Government Affairs Operations Specialist at VNS Health, New York's largest nonprofit home and community-based healthcare organization. Thank you for the opportunity to testify today and holding this hearing on maternal health. VNS Health helps New Yorkers live, age, and heal at home and in their communities. Through our Bronx Nurse Family Partnership, we support low-income, first-time mothers from early pregnancy through their child's second birthday. This work is partially supported by the City Council's discretionary funds, and we're greatly appreciative to the Council for that. While nurse home visiting is one of the most effective ways to improve maternal health, it works best alongside system-level measures that strengthen the continuum of care. Transparent data collection and coordination, like the Council has talked about today, as well as my fellow panelists, are essential to ensuring that our mothers receive the care they need. We want to especially highlight resolutions 1085 and 1086. Through our Nurse Family Partnership Program, we've served more than 7,600 families in the Bronx since 2006, and that's 7,600 mothers that our nurses have worked extremely closely with. They know that adverse health effects for mothers happen both before the pregnancy and after the pregnancy, both before birth and after birth. Resolution 1085 takes those realities into account and makes sure that adverse maternal health effects and issues are taken into consideration. As a home health agency, Venus Health has also seen firsthand how new occurrence codes can improve how health issues are tracked and addressed. We appreciate Resolution 1086's use of existing technology to establish new occurrence codes and better identify and track adverse maternal outcomes. We know that these resolutions may add additional administrative responsibilities, but all 4 proposed resolutions represent sound public health practice that we absolutely support. We thank the Council for its ongoing leadership and investment in maternal health, including our Nurse Family Partnership work. Thank you for the opportunity to provide testimony today.
Thank you. I would like to disclose, for disclosure, that I work for Visiting Nurse Services and I work for H&H Elmhurst Hospital Emergency Room. So I just have to let it be. so I'm not favoring it, but I want to say thank you for being here.
Thank you.
Thank you.
Bye.
The next panel is Beth McGovern, Mia Ragnar, and Sarah Mum. And if I butcher your name, you can kind of clarify it for me. That's all right.
It's McGovern.
Sorry, you may begin.
Good afternoon.
You have it on.
It's on? Okay. Good afternoon, Chairs Narcisse and Lewis and members of the committee. My name is Beth McGovern, and I serve as the Associate Vice President. I serve as the Associate Vice President for Quality and Clinical Initiatives at the Greater New York Hospital Association. I'm a registered nurse, and I have a doctorate in nursing practice and a certification in patient obstetrics. And I thank you for the opportunity to testify here today on maternal health. Greater New York Hospital represents all hospitals in New York City, both public and not-for-profit, as well as many more throughout New York, New Jersey, Connecticut, and Rhode Island. We're proud to serve on Speaker Adams' Maternal Health Steering Committee with partners across the city and state. We've all heard today the statistics. I don't need to repeat them, but we agree they're not acceptable. Black women die at a rate of 5.3 times higher than white women in New York City during and after pregnancy, and these disparities persist regardless of income, education, insurance, showing that they stem from systemic inequities. Hospitals provide most of the perinatal care in the state, especially for Medicaid and uninsured patients, and we know that one of the major issues in the care of this population is addressing social determinants of health. Approximately 80.3 birthing people experience at least one social and emotional stressor before, during, and after pregnancy. Many health challenges are tied to housing, food insecurity, transportation, and childcare. Greater New York Hospital Association supports the state's social care networks under the 1115 Medicaid waiver to connect hospitals with community-based organizations to assist in mitigating these factors. But as we're all aware, we're worried about the federal cuts under the One Big Beautiful Bill Act that threaten to worsen these challenges and may force some hospitals to reduce their maternity care services. I wanted to take a few minutes to highlight some of the initiatives that Greater New York has been a part of with our partners throughout the city and state. As mentioned earlier by Dr. Wilcox, we participate in the Safe Motherhood Initiative, which is a collaborative to address the leading causes of maternal mortality and morbidity. We participate in the New York Perinatal Quality Collaborative NTSV Cesarean Reduction Project, which focuses on safely reducing primary cesarean sections, as well as looking at race and ethnic disparities that persist among cesarean delivery rates. We've also been a part of the Hospital Doula Friendliness Project, and we support the Maternal Mortality Review Boards. We're really asking for you to continue to partner with us to protect hospitals from federal funding cuts, strengthen Medicaid, and invest in the social safety net that's available. And thank you for your leadership and the opportunity to testify today.
Thank you. Thanks.
Good afternoon, and thank you for the opportunity to testify. My name is Mia Wagner. I'm Director of Health Policy at the Community Service Society of New York. CSS is a 180-year-old organization that aims to build a more equitable New York for low and moderate income individuals. Our health programs assist over 130,000 New Yorkers annually through a live answer helpline and partnerships with community-based organizations. CSS supports the proposed resolutions to improve the reporting and tracking of adverse maternal health events in New York City with several recommendations to enhance transparency and ensure thorough data collection. I've included those in detail in my written testimony. We also have 3 other evidence-based recommendations to prevent maternal deaths that I haven't heard discussed yet today. First, requiring all patients who have given birth in New York City to be discharged with an automatic blood pressure cuff. The 2025 report found that the second leading cause of pregnancy-associated deaths in the city was cardiovascular conditions. A national study found cardiac conditions make up over half of postpartum deaths, occurring between 43 days and 1 year after birth. The NIH found that the risk of postpartum cardiomyopathy is 6 times higher among Black women compared to white women. A previous New York City report included a table of the underlying causes of pregnancy-associated deaths by maternal race and ethnicity from 2016 to 2020. While the report refines that overall the most common cause of pregnancy-associated death is mental health conditions, the most common cause of death for Black women was cardiovascular conditions, which was shielded in the overall findings. This new report did not have that breakdown, which is critically important to understand different outcomes. Sending patients home with an automatic blood pressure monitor is a proven method to catch postpartum hypertension early. It's cost-effective and leads to decreased emergency department visits. Second, we're recommending that all patients with Medicaid who have been given birth in the city be discharged with a scheduled home visit. And then third, we're asking that the city leverage its surveillance systems to document and investigate near misses and preventable maternal deaths. Thank you.
Thank you. Next.
Good afternoon, Chairs Narcisse and Lewis. Thank you for the opportunity to testify today. My name is Sarah March. I'm the director of the Young Mothers Program for Samaritan Daytop Village, We serve pregnant and parenting women with mental health and substance use disorders and have been doing so for more than 50 years. I'd first like to thank you for your leadership on maternal health and for the new funding supporting our program. Your investment recognizes that improving mental health must include mothers facing behavioral health and addiction challenges. Across the city, overdose is now a leading cause of maternal death, and Black and Latino women remain far more likely to experience serious complications. Yet stigma continues to prevent too many mothers from seeking help for depression or addiction for fear of judgment or family separation. Beyond these numbers lies a deeper barrier, which is stigma. Too many mothers fear that seeking help for these mental health disorders or addiction will lead to judgment or family separation. If we want to save lives, we must create a system where mothers are met with compassion and not punitive or punishment. We want to bring this council's attention to City Hall's new maternal health initiatives, the family-focused maternal behavioral health clinic at Lincoln Hospital, and the crib pilot connecting 300 pregnant New Yorkers to housing. These are very important steps forward. As the city expands this work, we are urging health and hospitals and DOHMH to partner with community-based programs like the Young Mothers Program. We bring decades of experience, culturally responsive care, and lived experience that can strengthen clinical systems and ensure that no mother falls through the cracks. Every day, we see our mothers rebuilding their lives, staying with their children, and returning to our community as strong, self-sufficient parents. With your continued partnership, New York City can become a national model for maternal health that treats every mother with dignity and compassion. Thank you.
Any questions, my colleagues? Any questions? No. So I just want to say thank you for coming out to share your testimony with us. I appreciate you. That's it. Okay. Got it. Thank you to all of you who came here to share your thoughts and experiences today. If there is anyone in the chamber who wishes to speak but has not yet had the opportunity to do so, please raise your hand and fill out an appearance card with the Sergeant at Arms at the back of the room. Anyone else? I guess none. Seeing no hands in this chamber, we will now shift to the Zoom testimony. When your name is called, please wait until a member of our team unmute you and the Sergeant at Arms indicate that you may begin. We'll start with Tori Newman Campbell.
Starting time.
Good afternoon. Can you all hear me?
Yes.
Good afternoon. Can you hear me? Okay.
Yes, we can. Thank you.
Thank you. Good afternoon, members of the council. My name is Tori Newman Campbell, and I am testifying on behalf of 1199 SEIU. 1199 SEIU would like to thank the City Council Committees on Hospitals and Women and Gender Equity for holding this hearing on this extremely important issue of maternal health in the city. Many of the people who went before me have already highlighted many of the issues around maternal mortality and morbidity, particularly for women of color. So I will just summarize my testimony for the sake of time. As a union representing many women of color working in healthcare, this issue is twofold for 1199. The vast majority of our members are women of color, so many have or will experience the joy of childbirth along with the fear of knowing that they are at greater risk of complications. From issues of access to affordable prenatal and perinatal care, discriminatory and racist maternal care practices, and limited support for postpartum mental health, we must do more to ensure the experience of giving birth is positive and safe for all demographics. As healthcare workers, they face the daily struggle of providing care to low income New Yorkers in settings that often struggle to recruit and retain needed staff and struggle to keep the doors open. With the increasing divestment from healthcare, such as the $1 trillion the federal government just stripped from Medicaid funding, workers are consistently being tasked to do more with less. We appreciate the city and state's commitment to this issue. So sorry. We Appreciate the city and state's commitment to this issue and acknowledge the emphasis on increasing access to programs that provide at home care, such as midwives and doulas during childbirth. The resolutions introduced today are another step in the right direction to ensure we are prioritizing the health and wellness of pregnant people as they are going in to give birth. Having correct data on any adverse maternal health events helps us to identify patterns and needs. The city also needs to continue to prioritize the growth of the healthcare workforce, specifically for maternity care, so it looks more like the people being cared for. 1199 SEIU's Training and Employment Funds runs a career pathways program that works to support and empower New Yorkers to join the healthcare workforce by providing accessible, high
Time
quality training and
expired.
educational opportunities at no cost. This program is made possible from collaboration at the state, federal, and city level. And programs like this will help continue to strengthen the healthcare workforce. I'd like to thank you guys for your attention to this issue and for allowing me to testify here today.
And thank you for your time. The next is Iman Ramari Duster.
Starting time.
Hi, thank you so much. My name is Emmanuel Maui Doster. I was invited to this hearing and I wasn't sure if I was even going to be able to make it, so I also submitted my testimony. I heard a lot of great information during this hearing, but I didn't hear enough information about accessibility and the trainings for medical providers to support more people with disabilities with chronic illnesses. Yes, mental health is super important, and so is chronic illness. I am both Black and Palestinian. I have lupus, I have a heart issue, I have a blood clotting issue, I have a nerve damage issue, and I'm a double amputee. I also lost 3 pregnancies. And my second pregnancy caused me to become a double amputee 13 years ago. And the doctors at Bellevue didn't listen to me at the time, which caused the blood clots to turn my feet black. My third pregnancy was caught at 6 weeks, which caused my heart doctors, and my rheumatologist to suggest that I get a DNC rather than continuing my pregnancy because of my heart. It was incredibly traumatic for me. And they said that if I stayed pregnant, neither me or my baby would survive. The gynecologist that I saw after my procedure was incredibly nasty and insensitive towards me, and he had no care for me whatsoever. This was at New York Presbyterian. I lost my legs at Bellevue. Nothing was reported, and I was actually blamed for my treatment. Not only do these trainings need to require more cultural sensitivity, but it also needs to include disability sensitivity. There are over 116,000 parents who have given birth in New York City with disabilities, and we're not getting any of that support. This also needs to be done in an intersectional way. And if there are language access needs, that also needs to include ASL. Since I have active lupus and I've had it in my body for the last 26 years, I've gone through a number of issues with doctors in all these hospitals. And I've seen the hospitals in Queens as well, which have also been awful. It's amazing that MOPD isn't here. And it's amazing that we're not speaking about this in a more intersectional, holistic way, because yes, I am Black, I am Palestinian, I am also physically disabled, and I also have a chronic illness. And unfortunately, I won't ever be able to give birth because of my issues that I've had before. So I'm hoping that we're considered next time for this hearing, but also considered for the hospitals, since we are here and we do give birth and we are parents. So thank you so much.
You are so right. I I I'm sitting here. I'm embarrassed to not having touched that. And I promise you, the next time we have to think thoroughly and not leaving anyone out. You matter, and everyone else in our world matters. So we have to pay attention to have question in addressing the disability. Especially, I know about lupus for firsthand because I have my colleagues that always talk about her struggle with lupus and any kind of disabilities. So if you find that we did not address it enough or we kind of like fly over it, that's my apology. So thank you for your testimony and thank you for your time. And advocates like you make the difference in New York City. So thank you again. The next is Alex Stein.
Starting time.
All right. Moving forward, and I'm so happy that this young lady was able to correct me in some aspect. And moving forward, we'll look into it. If you are currently on the Zoom and wish to speak, but have not yet had the opportunity to do so, please use the raise hand function and our staff will unmute you. None? Seeing no hands, I would like to note that everyone can submit written testimony to testimony@council.nyc.gov within 72 hours of this hearing. To conclude, I am grateful to be part of a council that has taken action to address the maternal health crisis in the city. And I look forward to contributing to that work in the future. And all of you, I hope, just like this young lady stood up and told us, I would like to thank everyone who has taken time to testify today. Thank to healthcare professionals who take care of our fellow New Yorkers. And thank to all the staff, and especially my Ria Ogazawara that helping me so much, and all my staff, and of course, for preparing um, this hearing for us. I want to say everyone that, including, I know Josh is not here, but thank you, Josh. And now I'm going to turn it over to my colleague if she has any additional closing that she wants to.
I just want to thank you, co-chair, for partnering on this hearing today. It definitely provided us with a lot of information on what different folks are going through, and I know it's something that we can tackle with our colleagues. I want to thank everybody that came out to testify today, whether digital or in person, and we look forward to continuing to work with you.
Thank you to my co-chair, Farah Lewis, for being awesome as women equity is very important to us. And thank you to Madam Speaker that left. She's very passionate about this. And of course, we've been pushing forward with mental health, any kind of disabilities. And most importantly, I want to say thank you to Sergeant at Arms that keep it flowing. So to that, anyone else? Then I will close.